Good evening, friends. All the panelists, I'm very thankful to you for being here, and all the viewers who have spared the time for this webinar. It is an honor, my pleasure to introduce the esteemed faculty today. And we are very thankful to Dr. Gao and Dr. Tom Lee, particularly, who have you just spared their valuable time to be with us this evening. So first of all, I would like to introduce Dr. Tom Lee, who is a graduate from Columbia University and has done fellowship in foot and ankle surgery from the famous Thomas Jefferson University Hospital, Philadelphia. He is founded Orthopedic Foot and Clinic Center in Ohio, which has been giving training to lots of surgeons from all around the world. He is a past president of AOFS and chief in foot and ankle surgery in the Ohio State University, and he's examiner for the American Board of Orthopedic Surgery, reviewer to Foot and Ankle International Journal of Bone and Joint Surgery with more than 75 peer-reviewed papers, and he is involved in many active designs with different companies. He has got many designs patent. We welcome you, sir, for today's webinar, and we are indeed very thankful to you for joining us. Secondly, I would like to welcome Dr. Gao. He is a consultant orthopedic surgeon and foot and ankle surgeon from Raffles Hospital, Singapore. He is an honorary senior lecturer in Nanyang Technical University, Singapore. He is a course instructors in Arthroscopy Association of North America and Royal College of Surgeons of England. He is a senior clinical lecturer in Yonglou Lin Medical School, and he is a scientific program chair for CCOT and chairman for the foot and ankle section of the CCOT. He is also national delegate of CCOT for Singapore, and he has 34 peer-reviewed publications. Welcome you, Dr. Gao. Now it is my pleasure to introduce the Indian faculty, and like every webinar, it has to start with Dr. Rajiv Shah. The permanent feature of all these webinars, a foot and ankle surgeon for Sunchild Global Hospitals, Vadodara, Bharuch, and Surat, Executive Council member of the Global Foot and Ankle Council, a Vice Chairman in Asia Pacific Foot and Ankle Council, then South Asia Coordinator for the International Advisory Board meeting Foot Innovate. He's a past president of Indian Foot and Ankle Society, and is well known for his handbook on foot and ankle, which was awarded as the best book by the Bombay Orthopaedic Society. So now I move on to the next line of panelists, and it is my pleasure to introduce Dr. Kamal Dureja, who is a consultant and head of foot and ankle surgery at the Max Specialty Hospital, Saket, New Delhi, and he has been faculty to many foot and ankle courses. Then I welcome Pradeep Manoop, foot and ankle specialist and sports medicine specialist from Breach Candy Hospital, Reliance Hospital. He has been trained in UCH London, and he has more than 150 international and national publications, and he is reviewed to various national and international and his journals, and he's a committee member of the American Foot and Ankle Society. Then I welcome Maninder Shah, who is the chief foot and ankle surgeon from the Indian Spinal Center, New Delhi. He is the editor foot and ankle section of the Indian Journal of Orthopaedics and associate editor of the Journal of Clinical Orthopedics and Trauma, and a guest editor in foot and ankle annals of joint surgery. And then I move on to the next line of budding young foot and ankle surgeons who are going to present the cases today. Dr. Parthiban, foot and ankle surgeon from Chennai and executive council member of IFAS, AO fellow in Switzerland, and then again foot and ankle fellowship he has done from Switzerland. He has been faculty to many courses in India. Then Dr. Abhishek Jain, recently married. Congratulations, Abhishek, foot and ankle surgeon from Delhi, and he owns a Delhi Foot Clinic. So he has a fellowship in foot and ankle surgery from Germany, South Korea, and he has also an active member of IFAS and national faculty to many BOFAS courses. Our Indrajit, who has been very active in organizing these webinars. He is foot and ankle surgeon from Delhi, and our webinar coordinator. He has done fellowship in foot and ankle surgery in University of Alabama and is an executive member of Indian Foot and Ankle Society. And then Dr. Gurunath, he is from Solapur. He is an assistant professor in VM Medical College. He has Solapur, and he has done fellowship in UAB and Lee Shaw Fellowship from National University Hospital, Singapore. And finally, the last young surgeon from Jaipur, that is Rahul Upadhyaya, who has done fellowship in foot and ankle reconstruction in Singapore. And he's a founder of the Jaipur Foot and Ankle Society. And he's an ex-committee member of Indian Foot and Ankle Society and a member of the CCOT Foot and Ankle Committee. And now I hand over to the moderator, Dr. Rajiv Shah, to invite the first speaker.
Well, good evening. You might not see my face, but you would be able to listen to me. We will go in this manner. First, pathoanatomy of the calcaneus malunion would be introduced by Dr. Pradeep Munur, and thereafter we will have case presentation and discussions. The most important thing is that we have on board my own mentor, Professor Dr. Tom Lee, who has been very kind to join with us in this webinar, and I especially acknowledge his presence into this webinar. So over to you, Pradeep. Pradeep, you can start your sharing your screen.
Indrajit, can you give the screen to Pradeep?
Already with him, sir.
Okay.
Dr. Pradeep.
I think he can't. Can he hear us?
Yes,
Right here, a second back.
We have lost it somewhere. Should I give him a call?
He's rejoining, sir. It is dropped off. He's rejoining. We can introduce Parthiban, sir, till then. He's just joined us. Dr. Parthiban has just joined us.
Yeah, yeah.
Hello, good evening, Juan.
So, maybe if he's not able to join, can we ask Dr. Rahul to start with his case?
We can, sir. He's joined in, sir. He's come back.
Yeah, okay.
He's come back.
So Parthiban has just joined us?
Yes, sir.
No, I think we are waiting for Pradeep. Pradeep, is he joining, or we start with Rahul?
He is
here.
Okay, can you hear me and see my screen?
Yes.
Not yet.
Yeah, we can.
Not screen.
Just about starting.
It's
Yeah.
Okay. Thank you so much, Dr. Rajiv Shah, Indian Foot and Ankle Society, and the international faculty. I'll be talking on pathoanatomy of the calcaneum malunion. So start with a case. A 37-year-old doctor had an open fracture of the calcaneum almost 18 months back. He was treated with K-wire. He presented to me with this kind of deformity with the hind foot is going in valgus, pain on the medial side and the lateral side, finding it unstable on walking on uneven surface. And also you can see on the right side, the toes, also he was having clawing and difficulty in walking as well. X-rays were done on the right and the left side, and you can see a lot of things going on. Okay, so you can see exostosis here, flattening, lateral wall is widened, and also the CT scan here as well. So why are we going to discuss on calcaneum malunion and what is the plan or what do we do next? And Cotton in the right from 1908, he described that os calcis fractures are of interest because they give so large a percentage of cripples. And because these cripples are strong men as a rule in youth and vigorous middle age. Furthermore, he noted more and more a number of cripples untreated, very often diagnosed as sprained ankles in the early week. And I think this dictum still holds true in this era as well. So coming to what next, Before we do that, we need to understand the pathoanatomy of the calcaneum malunion, where what are the bones involved, the bony deformities, the tendinous structures, neural and other soft tissue involvement as well. So let's come to the pathomechanics. We know the fact that the axial load drives the lateral process or the talus into the lateral wall of the calcaneus, finally affecting either an extra-articular or an intra-articular part of the calcaneum fracture. The tuberosity fragment translates laterally and superiorly. Thereby, finally, you have a reduction or a decrease in the height of the calcaneum. The decrease in the height alters the lever arm effect of the calcaneus. It also gives a talar, flattens the talar inclination, thereby reducing the talocalcaneum angle and thereby leading to fibular impingement. Also, because of the lateral blowout, there is increase in the width of the calcaneum, which results in a lateral exostosis, which has its own side effects. And we know the fact that more than 2 millimeters of displacement of the posterior facet changes the load-bearing characteristic of the subtalar joint, thereby leading to subtalar arthritis. So if we classify the problems with calcaneum malunion can be divided into bony problems, joint problems, tendon and neurological. I will take one by one. So let's talk about the bony problems. We know the fact because of the blowout, you have a lateral wall, which is the exostosis is there, leads to widened heel, which is called as a Kashiwagi syndrome. There are painful exostosis, which can have a problems in difficulty in wearing a normal footwear, especially the lateral bulge or the posterior bulge, and even on the plantar side. Because of the loss of the height, there is a loss in the there is a decrease in the talar inclination, thereby causing an anterior impingement of the ankle joint and reducing the dorsiflexion. And of course, if there is a severe deformity, you have a hindfoot, varus or valgus. The next is the joints. Usually the most common joint infected are the subtalar joints and the calcaneocuboid joint, which can lead to arthritis. Of course, in a long-standing deformity, the ankle joint can also get affected because of the talar tilt and also because of the anterior ankle impingement, thereby reducing the dorsiflexion. But ultimately, it can also give rise to osteoarthritis. We know the fact because of the hindfoot deformities, there is a calcaneofibular joint impingement as well. The third part is the tendons. Which are the tendons? The most common tendons involved are the peroneal tendons, which can cause either peroneal tendinitis or further leading to stenosis, impingement, and finally a subluxation or a dislocation of the peroneum. And this is again because of multitude of issues. Either the lateral wall is, there is a lateral wall widening, exostosis there, or a significant hindfoot valgus present. And finally, any neurological issues. And this is again because of the inflammation or irritation, either because of the posterior tibial nerve or the sural nerve. And this is because again, because of the multiple significant displacement of the medial fragments or the lateral fragments. Also, do not forget that these patients may have been operated. So post-op iatrogenic injuries to these nerves can also be an issue. And that's why these patients should be examined before we undertake any operative treatment for these patients. Radiographs are very, very important in these patients. We need a standing AP and lateral views, both of the ankle as well as the foot. You need an axial views or the Harris views. Do not forget the Broaden's view, because that gives you a good idea of what is happening in the posterior facet. And last but not the least, a standing Salzman view is very important, gives you a alignment of the hindfoot as well. CT scan is the mainstay of these patients for investigations. It's a very reliable tool. You need to see the CT scan. If you can get a digital copy, where you can actually cut the sections, look at both the 2D, sagittal and coronal views to understand what is happening with these difficult malunions. And of course, finally, you can do a 3D reconstruction, which helps in complete understanding and further planning as well. Coming to classification, the first classification was given by Stephen and Sanders, and it was a very basic classification, helpful, where the type 1 was lateral wall exostosis or a lateral with plus minus only the lateral side of the joint having a subtalar arthritis. Type 2, lateral exostosis with complete subtalar joint arthritis. And third was along with the type 2, but severe deformities. That was a very broad categorization of these malunions. What they failed to discuss was what was happening with the soft tissue, what was happening with the joints, other joints, what was happening with the hindfoot height. They did not look into this. So Zip and Remard further did a classification in 2003 where they classified from type 0 to type 5, where 0 was only subtalar arthritis or, a malunion without arthritis. Type 1 was with arthritis. Type 2 was with a severe varus or valgus deformity. Type 3 was with a loss of height. Type 4 with a significant lateral translation of the body. And type 5 where the ankle joint also get involved. They also, along with it, defined type A, B, C, where A was malunion, B was non-union, and C was avian of the calcaneum. And this almost gave a complete picture of calcaneum malunion and help in the prognosis as well as the treatment protocol. Our own Indian Dr. Rajiv Shah himself has a classification which is called the ADENO, which A stands for arthritis, D for deformities, E for exhaustosis, I for any implant issues, N for nerve problems, and O is for other soft issues. Dr. Shah was kind enough to share these slides. A, where you have subtalar joint arthritis. B, there is significant deformities of the hind foot. E is for exhaustosis, mainly on the lateral side. I, any implant issue, you could have a screws or plates. N is for nerve, mostly a sural nerves or a posterior tibal nerve. And O in other cases, looking at mostly tendo Achilles contractures or any other soft tissue problems. So what are the treatment goals of these patients? The most of the things you want to do is help this patient get rid of the pain and improve the alignment. Of course, initially a conservative treatment is always the norm, but if they fail, then you would like to improve the hindfoot alignment, decrease bony prominences, thereby reducing the pain. And the treatment consists of mainly bony reconstruction and soft tissue reconstruction. They go hand in hand. Bony, you have a lot of things in your armamentarium. You can do a plain exhaustectomy, in situ fusion, distraction arthrodesis, osteotomy or combination. And in soft tissue, you're looking at peroneal tendons, repair of it, Achilles lengthening, neurolysis, and if any other soft tissue issues are there. So coming back to our case, this patient who presented earlier. So what are the problems you can see? You have subtalar joint arthritis. You can see here. You can see here the lateral wall as well as the plantar exhaustosis here. There's a complete loss of Gissin's angle. The hindfoot, the posterior facet is completely flat, thereby leading to a loss of hindfoot height, thereby leading to anterior impingement in this case. And of course, there is a significant valgus deformity present. The same patient CT scan, what do you see? That's a calcaneum tuberosity, completely out of the alignment. And here you can see a peroneal tendons, how they are causing a calcaneofibular impingement. So this is what we did. A plantar exhaustectomy was done, lateral wall excised, distraction arthrodesis done, valgus was completely corrected, and that's your intra picture. Another case discussions, 57-year-old, he had an open reduction fixation done 2 years back, and you see that that's a hindfoot which he came with. The skin is also puckered on the lateral side. And that's the kind of x-rays which he came with. CT scan was done. And let's read the CT scan. So what are the issues we have? Joints, subtalar joint affected, and as well as the ankle joint is affected. On the lateral side, the whole lateral, you have a lateral wall bulge, exhaustosis present, severe valgus present, peroneal are impinging on this area. And of course, skin is an issue because it's a previous operated case, so we have to be very careful. So I got a 3D model and planned the cut where exactly the osteotomy should be done. And this is the pre-op and the post-op of the 3D model, and planning helped in the case. Patient went to do very well, and this is the post-op picture 1 year down the line. Another last case for discussion, 53-year-old male, open reduction fixation done 9 months back, and came to me with pain, deformity, unable to do activities, and see how the toes have been affected. This is probably a missed compartment syndrome post-operatively. And also you can see the scar present as well, which has healed. And you see this X-ray and see the CT scan. There is a calcaneum malunion present, not a severe deformities, but significant loss of the talar height as well. So what are the issues here? Subtalar joint is gone, non-union with calcaneum tuberosity and anterior process, loss of hindfoot height, skin, we have to be very careful. Toes have to be sorted out as well. And of course, implants were in situ, so that needs to be got rid before we do the surgery. So open it up, remove all the implants. Here you can see a gap, that's your talus right underneath almost going up to the floor. Allograph was done, reconstructed the calcaneum, got the height back and got the alignment back. So in conclusion, malunions, what things need to be looked at: significant varus valgus, malalignment or shortening needs to be looked at properly and planned properly. Joints, ankle, subtalar or calcaneocuboid joint are affected or not. Bony side, lateral wall, plantar side or medial exostosis present or not, that needs to be looked at properly. Tendons, peroneals and tibialis posterior tendons and FHL tendon, I would say, if they are causing FHL tendinitis, and neurological issues. A good pre-op clinical examination along with appropriate radiograph and CT scan is a must. And in your treatment, always do both bony reconstruction and soft tissue reconstructions. Thank you very much.
Thank you, Pradeep. And thank you very much for complete exposition of the topic. Can you stop sharing your screen?
Yes.
Can we ask Dr. Rahul to present his case? Dr. Rahul, start sharing your screen, please.
Okay, I hope my screen is visible here.
Yeah, it's working, Rahul.
Hear you.
Thank you. So I would like to thank IFAS here for giving the opportunity, and also a special mention to Professor Gao because he happens to be my mentor, and I'm really happy that he is here in this webinar. So we'll start with a very simple case of malunited calcaneum. So this was a young female who presented 6 months post injury, 24-year-old female. She was a recreational athlete and sustained injury to her left calcaneum due to fall from the parallel bars. She was diagnosed with a calcaneum fracture and was managed conservatively. And then later on, she presented with complaints of pain while walking and gait abnormality. So this was an X-ray where we can see that there was a tongue tab depression, complete facetal depression with mild varus deformity of the heel. So we did a CT scan and to look for the joint surface, the status of arthritis, of the subtalar arthritis, and the angulation, the deformity that needed to be corrected in both the planes. So, and we proceeded with the extensile lateral approach. So preoperatively, we had a thorough discussion with the patient about the various options available. And when we discussed, patient was not keen for the fusion surgery. She was young and she wanted to go back to her recreational activities and trekking activities. So though we explained her that she might need a surgery later on, even if we try to salvage her joint, but she was very much willing for a second surgery if needed. So we decided for a joint salvage here, and we went ahead with an extensile lateral approach. We did the lateral wall exostectomy, explored the facet. We see we can have a view of the joint facet here. We did an osteotomy in both the planes of the facet, lifted the facet using a joystick K-wire and got it realigned with the posterior facet of the talus. So after realignment, we did a temporary fixation with a K-wire. Under C-arm, we observed both AP and axial views to make sure that we have a reasonably good the axial view and alignment of the heel. And once we had achieved that, we went ahead and fixed with a small recon plate. Now this implant had to be used because of some misadventure over the table where we could not use the calcaneum plate. And this was the next best implant available to us, so we had to use this. So after this, we kept patient immobile for a period of 2 months or 8 weeks. After that, we started her on mild exercises of subtalar joint. And this was her 4-month post-op video. Now she was due to come again for a post-op scan, 6-month post-op scan, but due to COVID, she could not come, so we are waiting for this to get over. So basically, the main question that we get after this kind of surgery is how viable is the option of a joint salvage, especially what is the cutoff time where we can think about a joint salvage versus with a fusion of the subtalar joint, and is there a role of a partial facetectomy like a scoop surgery where we can take a part of the involved arthritic joint surface along with the lateral wall? So now this is open for discussion and opinion of the senior panels here.
So may I start with Professor Gao? Your viewpoint on this case, any questions, any comments you want to have asked to Dr. Rahul?
Yes, thank you, Rajesh. Can you hear me?
Yes, yes.
Yes.
Thank you. Rahul, that's a very challenging case, and well done in trying to get her back onto her feet. Can I just double check? She presented to you 6 months after the index injury, is that right?
Yeah. Yes.
Yeah. So I think the first thing I would say is this is a difficult situation. I mean, all calcaneal malunions are difficult. That's the first thing I would say. And it's a spectrum, but this is a difficult situation for 2 reasons. Firstly, because of her age and therefore her functional demands. And secondly, because it's 6 months down the line. And you have a patient who doesn't want to have a fusion.
Yes.
I must say in my practice, I would probably offer her a fusion or nothing. And the reason I would say that is because I think trying to reconstruct a joint 6 months down the line, and especially when they've had the associated bony and soft tissue consequences of having a malunited calcaneum for so long, it's actually the results are very difficult to reproduce consistently. But as with all cases, we have patients who accept that they may require a fusion in a delayed phase and they still want to go for reconstruction. And I think that's a reasonable approach. The second question of cutoff time. So I think this is a tricky question. The first thing I would say is there's no data out there that I'm aware of that tells us that beyond a certain time slot or time period, we can still do a reconstruction or salvage versus beyond a certain cutoff time where fusion. It's a bit like the Lisfranc joint as well. People argue about this a lot, about how long can you leave a Lisfranc joint before you have to proceed and fuse it, as opposed to try and salvage and reconstruct it. So I think firstly, there's no data. But I think the important thing in the setting of calcaneal malunions is the longer the patient is from the time of the index injury, they start developing complications, just like Pradeep has said. And the complications are phenomenal. They're huge. You start getting bony complications, you start getting soft tissue complications. And the things that we're talking about are the things that often the literature talks about is just about the joint reconstruction and alignment restoration. But everything else that comes with as a sequelae of the calcaneal malunion needs to be addressed as well. And I think the history and examination in a calcaneal malunion is absolutely critical, because the patient may present with pain that is not directly related to the alignment of the joint itself, in which case going in and reconstructing the joint or going in and fusing the joint may not necessarily solve their problem. So my answer to that cutoff time issue is there's no data, and I think I would treat it on a case-per-case basis. Finally, partial facetectomy. Ooh, I think that's very tricky. That comes under the realm of, people, there is some data about, or there's some authors that have talked about going in through cleavage planes of fractures and opening up the original fracture at its own cleavage plane and correcting the deformity at its cora, its original cora. I have no experience with that. I think that's a very difficult operation. I mean, I'll show some slides later about my kind of algorithm for dealing with, as far as surgical technique is concerned. But I think a partial facetectomy, I think, is a very difficult procedure, and I don't think the results are going to be consistently reproducible. So I wouldn't put that on the top 3 options on my list.
Thank you, Go. There is a paper, there's a Chinese paper who have done the osteotomy even as late as 8 to 9 months, even beyond that, for calcaneus malunion. So there is a literature support, Dr. Gao, for that. the more better way of lifting it is with the cases where you have a tongue type of malunion, like Rahul had shown. So more so with the tongue type of malunion, that you can do such an osteotomy even as late as 8 to 9 months or beyond, if you don't find the evidence of arthritis. Secondly, yes, for even a fresh calcaneus fracture, if there is a far lateral small fragment, I have many times removed that fragment. As long as you have a larger subtalar surface to connect and load bear, I think you can do partial facetectomy, partial removal of the articular facet. But these are my views. I would like to know view of my mentor, Dr. Chomley. Sir, over to you.
Thank you, Rajiv. I want to make a comment on cartilage metabolism, and that is, how does the cartilage of any joint stay viable? And we know that it has to have opposition to another cartilage, and it needs to be bathed in synovial fluid. So when you have a dislocation of a joint surface like this posterior facet, or as Dr. Gao said, how about a Lisfranc? Or let's take it to an extreme. How about a shoulder dislocation? How long can that cartilage be out of sync without being bathed in synovial fluid before the cartilage cells and the cartilage matrix ends up dying? And of course, we don't know that. We know it at the basic science level, that it's probably about 3 to 6 weeks, but we don't know. And so in my mind, 6 months certainly is a very long time for that cartilage to be out of sync or dislocated, not opposed to another cartilage surface. And so I agree with everyone that the primary way to go here would have been the fusion. Having said that, obviously this 24-year-old woman said, no way, I don't want to do that. And I think, Rahul, you did a great job getting it back opposed, because the secondary goal is, of course, to get the bony anatomy back, which you did a terrific job. You got the length back, you got the height back. And so should her cartilage die, and I think most of us agree that in a couple of years it probably will, it'll make the subtalar fusion easier later. In terms of removing elements of the facet, again, I think we're all aligned in this behind Dr. Shah, and that is, if it's a small piece, 10%, 25%, sure, get rid of it. If it's 50%, and obviously that's going to be a little bit more difficult, but a small piece, absolutely, as long as it doesn't affect the structural integrity. So on a basic science level, I think this was dealt with appropriately, and I do think we do have some guidance of how long a piece of cartilage can be out of sync.
Thank you, Tom. Dr. Rahul, there's a question by Dr. Rao that what is the risk of avascular necrosis of the articular fragment when you are doing after 6 months?
So I don't think that avascular necrosis should be much of a concern here, because we have well opposed bony fragment, and I don't see any reason that we have changed the blood supply to the calcaneum here.
Okay. Any comment from Dr. Kamal, Dr. Maninder, Dr. Pradeep? Any comment, any question? Yeah, okay. Start with Maninder, please.
So, thank you. Basically, what I would like to say in Rahul's case, I think the main point that worked in the patient's favor was that, as discussed earlier, it was a tongue type fracture, which is more amenable to reconstruction at a later stage. And that the other thing was there was not that much significant depression, which is more of a rotational component of the fracture that was there. I think you did a really good job opposing that back to its original position. And I think that's what worked in this patient's favor. If it was like a comminuted, more of a depression type of fracture, then that would have not been that amenable to this kind of reconstruction at this stage. Yes. So I think that's what maybe worked in that favor. Thank you.
Kamal, please.
So, one thing we should bear in mind that all the calcaneal reconstructions, which we do even at 2 weeks or 3 weeks, and there is a paper in which at the time of reconstruction, they have taken the samples of the cartilage of the posterior facet, and they found anywhere between 20% to 30% cellular death taking place even at 2 to 3 weeks. So we expect that by 6 months, the cellular death would have increased to a much larger level. So basically, we are just in doing these kind of reconstructions, and that too in Indian scenario, you know, it's a big risk because patient, once it fails, he doesn't, you know, he doesn't say that it failed because we've attempted. He says because it was done and it has failed. So it's better that you must have in writing a consent from a patient that there is a high probability of this kind of a reconstruction still continuing to give you pain because of the arthritis which is going to supervene. And yes, of course, the bigger the size of the fragment which you're lifting in late reconstructions, the better our chances. So I think the patient did well because there was a big fragment which was lifted and which was put back into position. So that's all I have to add.
Yeah. Thank you, Kamal.
So can I ask a question?
Yeah.
So can I ask a question to Rahul?
Yeah, please.
In such cases, would you like to counsel your patients that if on the table you find that the articular cartilage is not good enough, you should go ahead with the fusion right at that point, because you may not get the right impression on the CT scan what is actually the status of the cartilage.
Yes,
If
yes.
only when you open you find it out that it is gone, then was it like that you wanted to counsel your patient?
Yes, sir. She was counseled regarding this. I did explain it to her that if I see that cartilage is not at all in a shape of being, to be salvaged, I would do a fusion right there. But since, as I said, that patient was absolutely not willing for a fusion, she blatantly said that if there is a 1% chance of saving this joint, do it. So
I just wanted to convey that we should keep this in mind, when you're doing such a...
This was after I have done this case, and there is not a very long follow-up. Probably like the video is 4 months post-op. Now it's been like 6 months post-op and patient has not yet been able to come because of the COVID for the scans. And we are yet to see what are the implications, probably like 2 years or 3 years or 5 years down the line, how long the joint can continue to perform in a good way. So that's why this is much more open discussion we can have here.
Great job done.
Thank you, Rahul. Pradeep, you have made a quick comment, please.
Yeah. So just on the fascectomy, how much facet you can remove? And I think if you look at Stephen and Sanda's classification, Sanders, when he said the type 1, he said was you could do, he said only lateral wall exhaustectomy. And also, when you do that exhaustectomy, lateral wall arthritis, you can literally take a 25 to 30% joint off as long as the joint is stable. And you already rightly said, I think as long as 70% of the joint is normal and load bearing is good, I think you can easily sacrifice it. That's it. Thank you.
Thank you. So before we go to Dr. Gurunath, there is an article and there is a study by Guang Rong Yu and Stephen Ramelt and group. These 2 studies are there onto osteotomy for malunited tongue type depression fracture. And they have said that beyond 8 months post-injury, the results are universally bad. That is what is their observation. The study was done in 2016 and 2017. Okay, over to Dr. Gurunath for your case. Please start sharing your screen.
Thank you, sir. Can you able to see my screen?
Yeah, you can.
First of all, I thank IFAS, Indian Foot and Ankle Society, for giving me an opportunity to present this case. So this is very interesting case done in 2016 when I was about to start my career as a foot and ankle surgeon. So 40 years male presented to me. He was non-smoker, non-diabetic. He presented with 2 years old malunited calcaneal fracture. There was a history of fall from height. Then he went to an orthopedic surgeon and below knee slab was given. Then he lost the follow-up and he went to quacks and there was history of massage. So he presented with me pain in while walking, difficulty while walking. On examination, there was tenderness all over lateral aspect of the ankle joint. Clinically, there was a gross heel varus. So these are the preoperative X-rays. You can see there is a very well appreciated heel varus with some sort of rotation. And you can compare on the normal side, that is right side. So if you see the axial view, on the right side, you can see the normal heel, and this is left side. See the amount of heel varus, and there is a component of rotation also. So I discussed with the patient, and I told him that he will need surgery and he may land up in subtalar fusion also. But he was not ready. So I discussed with him, and then I decided to do lateral closing calcaneus osteotomy, bring back the tuberosity back, and see the condition of the subtalar joint, whether it is okay or whether he will need the fusion. So on table, this is the lateral oblique X-ray is oblique incision taken. And I decided to take a wedge according to the Elizarov principle that at the core of the deformity, I took the tracings, and it was about 1.2 centimeters of lateral closing wedge. So I took the wedge, and with the help of 2K wires, then I closed the osteotomy. These are the intraoperative C-arm pictures you can see. And I could do the remarkable correction on table. The surgery done on 5/10/2016. He was on slab for 6 weeks, non-weight bearing for 3 months. He was all right for almost 1 year. And after 1 year, I did the screw removal procedure, and then he lost the follow-up. And he came, and this is the post-op X-ray you can see. And retrospectively, when I think there was some sort of residual varus is there, and some rotational component was there. So patient came to me after 2 years, and he was having pain while walking after long hours. He was a farm worker. So then I took the CT scan. Probably some sort of early arthritic changes were there, and some residual varus deformity, and some sort of exostosis remaining. And this was the follow-up X-ray after 2 years, after the CC screw removal. So these are his complaints. So this is X-ray on 10/11/2018. Then he lost the follow-up. I said he will need surgery, probably subtalar fusion, but wait and watch for 1 year, six months to 1 year. So suddenly he disappeared, and again came back after 3 months with severe pain while walking, discharging sinus from the lateral aspect. And when I asked him, he told he got operated for second surgery outside on 27 November 2018. That is almost 2 hours from the first surgery. And unfortunately, he developed some subclinical infection and severe pain. So this was the X-ray when he presented to me. So this is the screw and some lytic lesions in the talus and the subtalar joint. So I told him we have to remove the screw and wait till the infection subsides. Then I did all the blood investigations, CT and MRI. You can see the CT also. There are some infection changes. This is the MRI, also shows some subtalar joint involvement, probably the anterior facet. Then I told him, remove the screw, control of the infection, wait and watch, and then finally he will need subtalar fusion. Then I planned the third surgery, and I posted him for the subtalar fusion. I took the extensile approach. I did lateral bumpectomy. There was a lot of fibrous tissue, probably post-infection. And on table, I thought I could, there is some residual heel varus. So I did the calcaneus lateral osteotomy, and I derotated the calcaneus and tried to pull the posterior tuberosity at the normal position. And I did this subtalar fusion with 2 screws. So this is the clinical photograph before the final surgery. This was the first surgery when I did the lateral closing wedge calcaneostomy. This is the second incision he had done outside, and this is the third incision, that is the lateral extensile approach. So these are the intraoperative clinical pictures. You can appreciate that there was still some residual heel varus was there. And this was the apex. You can see here. So this is the X-ray after 1 year after the final subtalar fusion. So the now patient, these are the clinical photographs. Patient is fine. This is the final clinical photograph. So to summarize, patient has got 4 surgeries. First is only calcaneal osteotomy. Second is removal of the CC screw. The third surgery is removal of the screw due to some infection. And the final surgery is subtalar fusion along with the calcaneal osteotomy. So some questions still remaining in my mind. What could have been done better in this case on day 1? That is 1, is there still any residual varus remaining or any rotational component is remaining? So these are the questions to the panels and the seniors. Thank you very much.
Thank you, Dr. Gurunath. Excellent case presentation. I would like Professor, if you could put your X-rays of last final post-operative X-rays, if you could put. And,
yes, sir.
May I ask Dr. Tom Lee to come up with your comments onto this case?
Yeah. There are 2 questions that I have in my mind. Is why did he have continued pain? Did he have continued pain because the heel tuberosity was still in varus, or did he have continued pain because he had some element of subtalar arthritis post-traumatic? And obviously in your final operation, you fixed both. You did a revision of the tuberosity osteotomy and you fused the subtalar joint. So we don't know, but to learn from the case, I'm trying to figure out which it is. And in my mind, my conclusion is the heel tuberosity, is that what might have been done better is at the very first operation, if you had a more aggressive osteotomy with a little bit more derotation, maybe he would have avoided abnormal stress on the subtalar joint and never needed any of the others. But in the end, when you watch him walk, you certainly have accomplished the goal of getting him back to full function.
Yeah. Professor Go, your comments?
Can you hear me, Rajiv?
Yes, yes, go ahead.
Lovely. Hi. Yeah, so I think that's a phenomenal case, and I think the message that we're getting very clearly is that calcaneal malunion typically may involve multiple procedures. Hopefully, fewer the better, but it's not unusual that they end up having multiple procedures. So I completely echo what Tom says, but I'll expand a little bit more. So this is a 40-year-old guy who's a farmer who came in 2 years after his original injury with a varus heel. And I would suspect, even not having the video of him walking on day 1, I suspect he probably already had midfoot rotation and forefoot rotation as a result of this varus deformity. So a hindfoot-driven forefoot deformity, which he's been compensating for and walking on, which may or may not have resulted in a significant component of his pain. So when he has his first operation and the surgeon rotates his heel to try and correct the heel, it's just as important to address the midfoot and forefoot sequelae that have resulted from this deformity over a period of 2 years. Now, it might be that the reason why the pain continued after the first operation is because the subtalar joint wasn't quite fully aligned by just the rotation, by just the heel osteotomy, because of the midfoot and the forefoot deformity. And so the pain, therefore, as Tom said, progressed. And now you have a issue where the subtalar joint is partly the pain generator, and the heel varus deformity, though it may have been corrected, the rest of the foot composite deformities haven't been addressed, and so the pain continues as a result of that. So my message, Rajiv, would be that when you have a chronic deformity like this in the hind foot, it's very important to address the residual compensatory varus in the midfoot and the forefoot as well in trying to restore the plantigrade foot. Addressing the calcaneal malunion in isolation may not necessarily resolve the pain that has been caused by the original injury.
So very well said, Go. Dr. Pradeep, you want to add something? You want to ask something? Pradeep, you have to unmute yourself.
Correct. I did that. Thank you. Can you hear me?
Yes, go ahead.
Yeah.
Yeah. So I don't know if Gurunath, I think this was an exciting and a very, very thorough presentation of and especially in India, where we know the fact that patients get lost to follow up for after 3 months or so. I think Gurunath has a very fantastic follow up this patient. Only thing is, as I said before, all calcaneum malunion need to be investigated. I know in the axial view, you just see a little bit of hind foot or the calcaneum tuberosity, but I would get a CT scan done. And if it shows a little bit of arthritis, I would not hesitate to get an MRI. As Gao has already said, he already had an element of arthritis at that time. And if at that time we would have had better information, I would have taken an extended lateral approach and probably corrected the hindfoot rotation and the hindfoot deformity much better. And if it was only mild arthritis, I would have saved the joint in a better way, I would say. Rest, I think Gurunath has done very well, finally getting an excellent result for this patient. Thank you.
Okay, Dr. Kamal, go ahead.
Yeah. So, as has been pointed out, the radiological analysis or understanding the pathoanatomy was not complete in the first day. So in all such cases of malunion who are presenting after more than 8 or 9 months, they must go for a CT scan, because the 3 dimensions which are available in CT will only tell us how exactly is the deformity. Second thing, the pain generator. Once the patient complains of pain and you are not able to understand what is the pain generator, on a clinic basis, you can do these differential injections to understand, is the pain being contributed by the Chopard joint, by calcaneocuboid joint, and then you have a better analysis, that probably the secondary arthrosis of the Chopard joint has set in due to persistent varus deformity. And then another guideline which I would say, with such severe varus deformities, it is best to do them in a prone position, because in prone position, you can see whether your varus is getting corrected or not. Doing these procedures in the lateral position and giving a lateral incision only is really deceptive, to understand whether you have been able to correct the deformity or not.
Okay, Dr. Maninder?
Rajiv, sorry, can I just make a very quick comment?
Yeah, please, please.
I just throwing in, just to stir up a little bit of a discussion. Can I just ask the panelists, talking about pain generators, does anyone routinely do selective injections in this kind of a problem where we are not entirely sure often clinically exactly where the pain is coming from?
Yes. In my series of 65 cases of calcaneus malunion, I've done multiple injections which are Siam guided or guided by ultrasonography. Yes, you wanted to add something, Kamal.
Yeah, so differential injections are required when you have an equivocal situation. You have a calcaneocuboid pain clinically, but you want to save the lateral column. You want to retain the mobility of the lateral column, but at the same time, you want to take away the pain. So that's when they come to your rescue.
So can I add something, sir?
Yes, Dr. Vora, followed by Dr. Maninder. And then we will move to next case.
So we have been talking about the pain generators in this case, but this patient has been in virus for around about 2 years. Why not we think ankle as a pain generator? Because there is a constant medial loading on the ankle also, so, for 2 years. So I just want to share that we should keep an eye on the ankle also on these cases because of the varus load. That's what I want to add.
Yeah. Maninder?
Yeah, I would agree that the alteration of biomechanics is the cause here, and the thing here that we need to really examine clinically, and I think the diagnosis is more clinical as well, is that whether there were actually any subtler movements left at 2 years with that significant deformity, and if there were not any subtler movements initially to start off with, then doing a joint sparing operation would have been, not a long-term solution. And that's what I would say, that if there are any subtler movements available, then we can, and then which are pain free, then I think we can think of joint sparing. Otherwise, we should be more aggressive in correcting the deformity as well as fusing the joint at the same time. So doing a in situ fusion plus a calcaneal osteotomy would have been the first choice, possibly, if there were no subtler movements, and that's what I would say.
Okay. So thank you, panel. And now may I ask Dr. Parthiban to start with his case presentation. Thank you, Dr. Gurunath. Dr.
Thank you, sir.
Parthiban, can you start sharing your screen, please?
So there was one question. Did you get it from Dr. Kalmakar? How you assess the distraction?
Okay. So maybe Gurunath, this is the question to you. How is the amount of distraction of subtalar joint you assess when you're doing a distraction talocalcaneal fusion? Okay. Any of the panel member would like to answer this question? Kamal?
Yes. So you look at the talo first metatarsal axis. That's your best guide, in the lateral view. So you got to get back when you put a lamina spreader between these posterior facet of the talus and the calcaneus. Start looking at the correction of the talo first metatarsal axis. And that's the best indicator, where to stop. You should either get them close to 0, maybe around 5, not more than 5 by the time you stop distracting.
Yeah, Dr. Rao, so far as I am concerned, I always take standing weight-bearing X-ray of the opposite side, which gives me an idea of the calcaneal pitch as well as talocalcaneal angle, and that is also one of the factor which I consider why I do a distraction talocalcaneal fusion. I think we go to Dr. Parthiban.
Yes, sir.
Go ahead.
I hope everybody can see my screen.
Yes, go ahead.
Yes, sir. So first, I thank the Indian Foot and Ankle Society for giving this opportunity to present this case. So it is a case of a 35-year man, 3 years old, malunited fracture calcaneum, treated with a native splint, and came to me after 3 years only. He came with a pain in the lateral aspect of the just below the fibula. That was his complaint when he came to me. That was his complaint. So in this, when we did it, his bolus angle was just 14 degrees. And this critical angle of Guysen was 155. And I just wanted to, because I can feel the bump on the lateral aspect, so just did a weight-bearing X-ray of the ankle, which showed that there is an impingement on the lateral malleolus as well. This was his clinical photograph. Sorry, this was a little dull. Actually, you can see the left side, which is broadened there. And then went ahead with a sinus approach. Went ahead, exposed the joint. I did a bumpectomy through this itself, just to make sure the bump is not impinging on the lateral malleolus as well. Then went ahead, used a distractor to see the joint surface. This was so much of this thing after debridement and everything. Took a tricortical iliac graft, placed it there. Fixed it with a couple of screws. This is 6 months post-operative period. It went on to heal well. This patient didn't had any pain or anything. Went on to heal well. This was the pre-op and the post-op bullous angle, as well as his pre-op and post-op critical angle of Gussain. Thank you. I think it was a very short presentation.
Oh, thank you very much. We just wanted this kind of presentation only. Now, again, the same question. How did you intraoperatively judged about the amount of lengthening you want to do?
So, as how the discussion went on, it was for the mid-axis of the talus and the first metatarsal. But that time, I just had the opposite side ankle just for a comparison, sir. Intraoperatively, I just compared with that. But this angle, I didn't see it during that period. This case, I would have done it almost 5-6 years back. I did it. So I don't think I would have done it with that angle, because I had a weight-bearing X-ray of the opposite limb for the ankle as well. I had just to compare the impingement levels, how it happened. And this also, I had an opposite limb for the comparison.
Any
Intraoperatively,
other,
I compared with it.
yeah, any other approach you would have used?
Approach, sir, apart from a synostasis,
yes.
Maybe an extensile lateral approach might have been a little more helpful to take out the bump and everything, sir.
Oh.
Maybe because this was one of my older day cases, like 5-6 years back. Maybe if I do it now, I may use a extensile lateral approach, which could have been much easier for me now.
Okay. Are you happy with your screws which you have used? Would you have used these kind of screws, or you would have used a fully threaded screws?
So fully threaded screws, I was not sure like how much it is. This gives a beautiful compression. This is a differential screws, what I use regularly. This has a different pitch on the either side. This gives a beautiful compression, sir, the screws. Sometimes, okay. In fact, I've used a single screw also in these, not in this case. Some cases I've used a single screw also, which gives an amazing compression. You don't need to be worried, sir. This is a very nice one, sir. This is from the Extremity Medical.
Maninder, would you have used fully threaded screws or partially threaded screw?
Yes, if once you got your graft in, it is automatically compressed. So I would have used, usually what I tend to do is to put one single compression screw initially and then a stabilizing screw but usually I would agree that, I would put at least one compression screw and one, as well as a single non-compression screw as well, a fully threaded and a partially threaded. But I would use at least one partially threaded screw to hold that graft down. But it has been shown that when you have an interpositional graft, the thread, if there's a thread in the graft, then it holds that better in position. So, but I would agree at least one.
Okay.
Yeah. So Kamal, your comments?
Yeah, so two things I always do. I use divergent screws. They are not usually parallel because we don't want the graft to collapse. So one screw, usually I also pass first one as a compression screw, which, sort of gives me a final position and maintains a good compression between all the surfaces, which would bring a faster rate of healing or union. And the second screw, I would always use fully threaded so that the graft is maintained in that position and no further collapse is permitted.
Yeah, to more clearly mention what I'll do, I'll put a lateral screw first because I want to correct the varus. That is going to be a compression screw, partially threaded. And the medial screw would be a position screw, fully threaded, and that would be in a divergent fashion, like Kamal said. So one would go into body, one would go into neck. Anyway, any comments, Dr. Pradeep, onto this case? Any questions, any comments?
So as I said before, I think in this, you see, and Parthiban has kept this slide, I would have definitely gone, and as I understand, I've not been too critical of Parthiban, this would have been in the initial days, but you can still see there is still a subfibular impingement present. I am not to be too critical, but that's why I think if you get a first axial view and you see a large lateral wall exostosis, it is always better to open up, go through an extensor lateral approach. You literally need to see the lateral part of your talus you need to excise this whole bump from the lateral wall. So and probably take a tip of the fibula also. Some studies have shown that you may need to take that also to correct your subfibular impingement. And that bone you can flip over, you can double it up and put it in your subtalar joint, and that also gives a beautiful correction. Rest, I think everything looks fine. Position of the screws and everything. In my few cases which I've shown, we have valgus deformity. So just do the other way around, as Dr. Rajiv Shah said.
Dr. Parthiban, there is a question from Dr. Rao that were there any wound issues if you by use of this sinus tarsi approach?
No, sir. I didn't had any, because I commonly use this only for MIPO also, for fixing a calcaneal fracture or subtalar fusion. I have not had any issues. But maybe it takes a little longer to heal, maybe because of the ooze. Sometimes there's a mild ooze from the fracture site and all this, but usually as per it heals well, sir. Unless and until if the patient is a smoker. Okay. I've had an issue with one patient who's a chronic smoker. I've burnt my fingers doing this calcaneum for that guy. Chronic smoker, and because the second post-operative, the wound was looking amazing. He was smoking on the third day in the room. I just told him, don't ever try doing it again. But I don't know, this guy kept on smoking and all got very bad. What bitter experience I have with this.
Thank you. Dr. Tom, would you have taken a sinus tarsi approach or a extensile lateral approach or a posterior approach for this case?
Well, you read my mind. You know, one of my favorite approaches is a posterior approach. I like the posterior approach because it's just lateral to the Achilles tendon. So it's posterolateral almost. I like the approach because the soft tissue envelope is excellent. Oftentimes there are other incisions laterally that I become very frightened. And with the posterolateral approach, you have a very good view of the tip of the fibula, and it allows you to decompress it. You know, it also allows me to fully distract the subtalar joint, which of course is compressed with laminar spreaders. If I do not take down the Achilles tendon, typically I will distract the subtalar joint as much as possible, which gives me a good idea of how much to elevate and how much bone graft that I need. And through the posterior approach, I have access to the posterior iliac crest, where I can actually have much greater amount of bone than the anterior iliac crest. I tend to prefer fully threaded screws because I believe that my interposition graft is already under compression, and I want to make sure that there's no risk of subsidence after I close up and allow the patient to walk at that point. So it's a great case. One other point I want to make, and why this is a great case, is it avoids a lot of the mistakes younger junior orthopedic surgeons make, and that is to fuse it in situ. So it's so easy to go in and say, let me just do the exostectomy, get rid of the impingement and fuse it in situ. And this demonstrates why that doesn't work. You have to get it out to length, not only for the decompression, because the decompression occurs through the entire motion of the ankle, but the other is, of course, on a young guy like this, is to restore the mechanical advantage of the Achilles tendon. So this looks like a simple case. It's a simple case because you did everything correctly and didn't fall into any of the traps.
Thank you, Tom.
Thank you.
There are two problems which I have noticed with the posterior approach. Is one, removal of complete lateral wall exostosis, because sometimes you are really not able to see that whether you removed adequately the lateral wall exostosis or not. That's one thing. And second thing, reposition of the peroneal tendons into the normal position and recreation of the superficial peroneal retinaculum. This, with the posterior approach, I have found little problematic. Maybe you could enlighten us onto this.
You're correct, Rajiv. It's very difficult to see the exostosis the way you do on an extensile or on a sinus tarsi, but I will make the argument that it's much better to feel it. So you can stick your finger in there and you can feel that impingement. Now, in regards to the peroneal tendons, through the posterior approach, I address the peroneals in the same way I do in the extensile, and that is as a full tissue cuff. So since I stay directly on the periosteum, stay directly on the bone, I elevate the whole thing as one sleeve. And so all of the benefits and the risks of doing that is exactly the same as an extensile because it's under one sleeve. So my recommendation is have confidence in the tip of your finger and then do what your finger tells you to do. And again, to repeat myself, it allows me to put my finger in there and take the whole ankle through a range of motion, which is the advantage of the posterior approach. You can see the dynamic impingement that occurs.
Great point. Dr. Go, followed by Dr. Vora, for quick comments, please.
I just want to just go back to the case really. It's interesting that we've talked about pain generators in the last case, and this patient came in with purely lateral-sided impingement pain and absolutely no anterior pain whatsoever. Now, there is some data out there that talks about the risk of non-unions and even delayed unions with interposition grafts. So is there an argument here to do a somewhat a lateral bumpectomy and just an in situ fusion? I know Tom has said that that's the wrong thing to do, but this patient had no weakness of push-off. He had no anterior pain whatsoever. He only had lateral-sided pain. And given the risk of non-union or delayed union, is there an argument to do an in situ fusion? Because I know there's data from Myson and from Roger Atkins to say that, you know, putting grafts in is a concern, and they don't heal as well, especially in patients who have no anterior impingement pain. We are trying to restore radiological alignment, but they don't necessarily correlate with functional improvement. Just being devil's advocate.
Yeah. So
okay. So let's get into a discussion on that, Professor Seth. So I agree, and that's why I said the easy way is to do the bumpectomy and to do it in situ. And I do think anterior pain or anterior impingement is the indication for really trying to elevate it. Let me make one other point. So I think there is a good argument for that. What I like about this case is that it was autogenous iliac crest graft. So when you look at the non-union rates of distraction arthrodesis, including Meyerson's, most of those were allografts, and those non-union rates were very high, 10 to 30%. There's been some series almost 50%. I feel that when the problem, as I said, with the bumpectomy and in situ is that even though the bumpectomy, exostectomy, sufficiently decompresses the pressure on the tip of the fibula and the perineal and the sural nerve, is that it's a static decompression, and that many of my patients have continued nagging pain laterally, even though I decompressed it. And so my preference is the distraction because I really get the joint out and allow that to do it. And when you do that, I do think an iliac crest graft is important.
Okay.
Can I ask one question to Tom, sir? Rajiv Shah, sir?
Yeah, go ahead, Pradeep.
So you, Tom, you mentioned about the posterior distraction. How difficult or easy it is to put a trapezoidal type of a graft where you are doing your either a varus or a valgus correction visually, to put a trapezoidal graft in the through the posterior part. We know the fact from the extensile approach, you can easily do it. You can actually see the whole graft. You can actually see the whole correction, but posteriorly?
I would actually maintain it's easier posteriorly than laterally because you see the full width of the subtalar joint and you can control it because I have two laminar spreaders in there. I have one medial, I have one lateral, and I do variable elements. And I will say, Pradeep, you know, for all of us who are doing much more complicated hindfoot arthrodesis and then failures, like ankle replacements, become comfortable with the posterior approach because the visualization is terrific. And again, for the younger members of the audience who may go in there posteriorly for the first time, you will be shocked with two things. You will be shocked with how deep that incision is. It is really far away from the Achilles tendon. And number two, you will be shocked with the amount of rotation, the rotation of what the ankle joint is, because it is really rotated. But once you become comfortable with that, oh, and then the third is make sure you know the difference between the subtalar joint and the ankle joint, because it's separated by a centimeter. So once you get over those three things, you will fall in love with the posterior approach.
Sure.
Okay,
Sure.
thank you very much.
You.
Great discussion. And the next case is also going to elaborate on to what we discussed. So over to you, Abhishek Jain.
Thank you, sir.
Can you share your screen, please?
Yeah,
yes.
What's it? Am I audible?
Yes, go ahead.
Is my screen seen by all?
Yes, seen. Go ahead.
Yeah. First of all, thank you for all the wishes and blessings that all you have bestowed on me. And thank you, IFAS, for the opportunity to present this case. So I start the case. This is a 60 years old lady, fall from height 7 months back, sustained left calcaneal fracture, treated with cast, comes to me with the pain on lateral aspect of hindfoot on walking with intermittent swelling. Pain is also there, a very diffuse kind, but mostly whenever I ask, where is the pain? She puts her finger at the subfibular area. So what we can see here on the X-ray, there is arthritic, there is obliteration of the Gizane and the Bowler's angle. There is a lateral bump on the heel. Overall, the coronal deformity is not there. There is no varus valgus as such. On examination, there is no coronal plane deformity. Subfibular tenderness is there. Subtalar range of motion is minimal, just a jog with pain. Ankle range of motion, dorsiflexion is up to neutral, and she is able to squat without any difficulty, pain, or impingement. She is a countryside lady, and squatting is something which she requires. Now, if we look at the talar inclination here, we would appreciate that there is a loss of height of the calcaneus. But at the same time, squatting is all right. So I would like to, okay, I first finish my case. So my diagnosis was calcaneal malunion with subtalar arthritis, lateral wall exostosis, and subfibular impingement, Ramel type 1. And my plan was lateral wall exhaustectomy with subfibular decompression and subtalar fusion. I take the opportunity to give a disclaimer. I didn't have an intra-op photograph, so I've taken the intra-op photograph from Dr. Kamal Dureja sir. So my position, intra-op position was lateral decubitus. Incision was lateral extensile. My steps was first subfibular decompression, subtalar joint preparation, and fixation of subtalar joint with 6.5 cc screw. And these were my final X-rays. Patient is still on follow-up, 6 months post-op. She is comfortable and the lateral pain is gone. No complaints. That's all. Thank you. So I have not done any distraction arthrodesis for her because she didn't have any anterior problem, pain or impingement.
Yeah. So Dr. Go, there is someone who is supporting your viewpoint, your comments. Then comments by Tom.
I'll make mine short. Rajesh, I don't want the audience to go away with the notion or the idea that a distraction arthrodesis is a bad thing. What I wanted to point out was that it needed to be done well, and it needed to be done for the correct indication. I think with this lady, it's the key thing that I would be concerned about in a 60-year-old who is 7 months post-injury and has what seems like subtalar joint pain is alignment. So I would be very careful. I know you said there's no heel varus or no heel valgus, but she's 60, and I would want to be very, very sure and meticulous that her either her Saltzman view or her heel bolus angle, or even better still, a weight-bearing CT. That's what I would do in my practice to make sure that her mechanical axis is normal. And if there's any doubt at all with the mechanical axis, I wouldn't hesitate to do a calcaneal osteotomy with the subtalar fusion.
All
Because
these X-rays are weight bearing. What we are seeing.
Sorry?
All these X-rays are weight bearing.
Sure, but what I'm getting at is it's the coronal view that I would be worried about. So if she has any kind of malalignment either in the tibia or in the ankle joint, which is resulting in the subtalar pain, and not just purely from the trauma per se, I would want to address that as well at the same time. Otherwise, she at 60, she's going to have a risk of ongoing pain as a result, and then you'd realize that it's actually not all coming from the subtalar joint, it's actually coming from the other joints because of a mechanically unsound extremity. So that's what I would say. I would say it's alignment, alignment, alignment. But as far as the technical execution and the choice of procedure, I think it's well done. I wouldn't do anything different.
Well, I think this is a perfect example of why Dr. Gao is so smart, and he's correct. So this is a great example of where an in situ fusion works well. I think the test that you used, the squatting test, was a wonderful test since she had no pain squatting. And so I certainly can't fault you for an in situ fusion on this. I will also add to Dr. Gao's point about the coronal line alignment. Take a look at this X-ray. If you look at the Saltzman view, the heel is still in varus. So if you look to the left and look at the lateral, which is not weight bearing, you can still see that there appears to be a slight cavus view, right? Mary's angle is positive and the metatarsals are stacked. Again, it's non-weight bearing. And so I think everything that Professor Gao just said is true, and it is something we should keep an eye on as she recovers. So I agree with him.
So can I add something, sir? Dr. Shah, can I add something?
He's rejoining. You can continue, sir.
There's a one question to Abhishek. Yes. That he says that heel was, you could get only up to neutral, the ankle. And even then the patient could sweat. Was actually she decompensating by, moving at the knee or something like that? It is very difficult to have a full squatting and you can move only knee up, ankle up to neutral.
No, what I meant was that when I did a passive dorsiflexion of the ankle, I could bring up to the neutral.
Only neutral, that's what I'm saying.
But she could squat, without lifting her heel. She could squat with full heel down.
So I maybe.
Why do you think that's possible, Abhishek? Because you should have almost 20 degrees of dorsiflexion to squat at least.
Squat. Yeah, that's what I mean.
Yeah.
How can you squat when your ankle is going just to 90 degrees? That is what I have my reservations. That's what I wanted to bring.
I believe maybe because she was trying to resist me, maybe, but my basic final litmus test was whether she can squat or not. So she could do that. So I thought that doing the distraction orthodesis.
I also use this test always. When I'm doing, I always ask the patient to squat when I'm getting a case of malunion of calcaneus, because this is a wonderful test by which you can just rule out ankle impingement. But most of the time I see if they cannot, they have ankle and they cannot squat. This is my experience. I don't know about the others if they have witnessed such things in their clinical practice.
And so many a times they compensate by lifting their heel. So I was pretty much sure.
That's what I'm saying. That's what I'm.
Yeah. So I was very much sure that she is not lifting her heel. So that's why the procedure.
Okay.
May I say something, please? Yeah.
Sure.
So there are certain objective criteria. There are certain subjective criteria. There are objective criteria. And I think when we are talking of science, we have to be objectively also very clear as to what we are dealing. So have the lateral view weight bearing for both the sides and calculate the talus first metatarsal axis bilaterally. Some people are known to have about 10-degree Meary angle bilaterally. So this could be the reason that even after, not having this talus metatarsal axis to 0 degree, she has a fairly good range of ankle motion.
Fair,
So
fair.
compare with
Yeah.
the normal side and
Yeah.
then probably proceed accordingly.
Yeah, fair, sir. Point taken.
Can I say something?
Yes,
Sure,
Yeah.
sure.
go ahead.
The talar declination. So do we have a consensus that if there is no signs of anterior impingement clinically, but the X-ray shows that there is loss of calcaneal height along with a reduced talar declination, which is not allowing the ankle to move beyond neutral, that we still don't need to do a distraction arthrodesis. We don't need to restore the calcaneal height. And if the patient's symptoms are only lateral, then we can just get away with an exostectomy and an in situ fusion. Is that the consensus? Or I think that because that's the point that's being made here at the moment. But is that, because I would tend to think that restoring the biomechanics is still important, that we need to restore the height of the calcaneum and restore the talar declination, even though the symptoms may not be that acute. As long as the anterior, the dorsiflexion is restricted, I think we need to think of restoring that. But I may be the devil's advocate again here. So I would like the opinion of Gao and Tom. What do you think?
I'll go first. So I would start off by saying that it's not an easy decision, because I think when we come to restoring the biomechanics, often with this kind of situation, I find that when we do a distraction arthrodesis and you restore the radiological correction, and the Achilles lever arm, as it were, is better restored, the patient tends to function better. But I think it really comes down to the patient selection. If we are 100% sure that there's absolutely no anterior pain at all, the patient has no muscle deficit at all, then my question is, if the arthrodesis is done and the patient then goes into a non-union, and I've had a few of those cases, one that's questioned then, well, if I had done this differently, would the results have been different? So I don't think the consensus is that we should not do distraction arthrodesis if the patient has no anterior impingement pain. I think the better consensus would be that if we're going to do a distraction arthrodesis, we should do it well. So we know that certain sorts of things don't work very well. For example, as Tom has said, allografts have a higher risk of non-union. We don't express the joint adequately, medial and lateral. I tend to do medial incisions and lateral incisions if I'm trying to correct the alignment and get the arthrodesis right. Sometimes I even use a medial distractor to make sure that I don't over tilt it. And I think making sure that the Achilles length is also restored, I think is very important. So I think that's more of the consensus rather than saying we shouldn't be doing distraction arthrodesis. Tom,
Okay.
over to you.
Yeah. So, Tom, you want to do some comment, or there's a question for Dr. Abhishek?
Let me add to Dr. Gao's comments.
Rajiv sir, can Tom take that question?
Add to Dr. Gao's comments before we get to the question, because when I look at my fellows or my orthopedic residents, their natural inclination is, of course, to be lazy. And so the natural inclination is, I want to do the in situ fusion and the exostectomy because it's easy. I think the approach is actually, I want to do the distraction and let me find compelling reasons not to do the distraction and to do the in situ. So if I had to look at my practice, about 80% of the cases similar to this would get a distraction with an autograft. When I find compelling reasons not to do it, and this case had very good compelling reasons. One, it had an exostectomy. The lateral wall was a little bit of a buckle and it wasn't a full blowout. So there really was a sharp peak that looked like there was impinging. And number two, she had a very excellent squat test and she was able to squat. So she had two compelling reasons not to do it, and subsequently it became successful. But the case previous, even though they did not have anterior impingement pain, the anatomy was different. And so there was a typical case where it had a great deal of impingement. It wasn't a simple exostosis. It was a whole wall that was buckled. And so there, the natural inclination was to do the distraction.
Okay, thank you. And now this brings us to the next case. Before I hand it over to Indrajit, there's a question that do you do gastrocnemius release, Abhishek, in such cases? Or when do you do gastrocnemius release for a distraction fusion? Abhishek.
Sir, till date, I have not done any gastroc release for any of the calcanean malunion fusion.
Okay. The answer to that is that if the case is quite old and you are really struggling to get the length, I have done gastrocnemius recession many times in long-standing calcaneus malunion. Okay, over to you, Indrajit, for your presentation.
Right, sir.
Yeah.
Abhishek, you need to stop sharing.
Yeah. No, I'm not sharing. Indrajit has already shared.
Okay, thank you.
We'll begin with the case. So this was a 1-year-old malunited calcaneum. It was basically an open fracture. I have left the video. So it was managed conservatively at his place in West Bengal, and he had infection. This was his CT scan after 1 year. So you can see the whole blowout there. There's bone loss. The 3D reconstruction view, the flattening. This is a small video, a clinical video. You can see it's fixed there. This was the incision which was taken, re-op markings. See, the heel was fixed in eversion. This was his normal position there. This on the medial side was a wound where there was an open fracture there. This was intra-op, the bone loss you can see. It was filled with the allograft. Almost 2 centimeters of bone loss, the 2 centimeters of allograft was filled and a distraction arthrodesis done. This was the full dorsiflexion checked in the intra-op C-arm and the full plantar flexion checked. The K-wires put intra-op and 2 divergent screws put and distraction arthrodesis fused. This was the post-op clinical picture. The eversion was cleared and this was the final image. So I'll take it up for discussion.
Yeah. So Dr. Pradeep, you have any comments on this fixation? If you can put your last slide in a shorter view. Indrajit and Pradeep, please come up with your comments onto this case.
Pradeep sir is not here, sir.
Yeah, Pradeep.
Yeah. Hello. Yes.
Yeah.
Yes, I'm here.
Indrajit, if you could put your last images of your case. Yeah. We are seeing a very magnified view.
I think, is that okay now?
No, it's not okay.
Yeah, that's fine.
Okay. Okay, go ahead. Pradeep.
So I think the hindfoot alignment is quite good. So there's no varus or valgus, but I'm not happy with 2 things. One is the amount of distraction which you have got because the talus is still almost horizontal. I would want to see a more inclined talus and the Meary's angles if you would have it a much better way. That's the first part. And the second is I probably had some lag, but I did not see actually a proper iliac crest bone graft as a block, a trapezoidal block I would put in. That really gives my distraction to the subtalar joint. Third, the fixation. It is almost starting at one point of, at a single point from the posterior tuberosity and diverging. I would have wanted to have 2 different starting points, get one or 2 into the body and another screw coming from the anterior part of the calcaneum into the anterior, almost like the talus neck, coming from the anterior part of the calcaneum to the anterior part of the talus. That's what I would have done the fixation. That's what I would have done it. Thank you.
Dr. Tom, your comments, your guidance to this youngster?
You know, I have very little comments. I'm looking at the X-rays, and I agree that it does not appear that it's been the talus has been restored back. It still looks flat, but other than that, I'm pleased with the fixation, and I'm glad there's graft in there. I wish I could have gotten more height, but sometimes you're limited in what you can do.
Yeah. Kamal, your comments, your advices. You have to unmute yourself.
Okay. Somebody, okay. Is it fine?
Yeah, go ahead.
Yeah. So if we go back to the CT scans, the primary goal before correcting these malunion is to study your CT scans well. And you have to study your same way, the way we do the classification in Saunders, and we look at the coronal view with the broadest view of the calcaneus. You know, that's the one view which will really guide us. So you have to look at that view and then see what all you're facing. You know, you are able to see the varus, you are able to see the subfibular impingement in that view, or maybe in one or two more anterior or posterior views. And then your goals have to be clear, because you have to first list your pathoanatomies, as Pradeep said very well, pathoanatomy. So unless you have your pathoanatomies listed, you probably will miss out doing one thing or the other. So in all the presentations, if the viewers, if the young doctors, they are first listing the pathoanatomies and then telling us how step by step they dealt with those pathoanatomies, and then probably everybody who is new to malunion will understand it well, and that's how also the error would reduce in correcting these malunions.
Quick comments by Gaw, followed by his presentation.
With a lateral wall blowout, or a small degree of a lateral wall blowout, and joint depression with talar declination, that's been restored well. I mean, this is an X-ray that's non-weight bearing, so a little bit hesitant to comment on the final position of the talus and the foot. So I've got nothing more to say on that really.
Okay. So you could go ahead with your presentation.
Okay.
Can you share your screen?
Can you see it, Rajesh?
Yeah,
yes.
we can see it. Yeah.
Yes, we can see. Go ahead.
Okay. I just put together a few cases just to highlight some points. Actually, to be fair, a lot of them have been discussed already. I'll just go through them very quickly because I know we're sort of coming towards the end, and we'll probably take some questions and comments sort of at the end. So this is I put this up to begin, which is just kind of a story that shows that calcaneal fractures are really a spectrum. So this is an open calcaneus with a medial-sided wound, dislocated TN joint and displaced tuberosity. And this is another guy who's a construction worker in a shipyard, treated slightly differently in an explosion. There was some thought about a non-operative treatment modality to begin with.
We are not seeing your screen, please.
Okay.
It's going fine, sir. It's going fine.
Yeah. Okay. Okay.
Yeah.
Yeah, we can see it.
Yeah. Go ahead.
Okay. So this is the second case. Something very similar to the first one. It's a construction worker who was involved in an explosion. There were some thoughts at the start whether we should be treating this non-operatively, but he then underwent 4 sequential operations and had almost 5 years of disability. And you can see the X-ray right at the bottom there. And I think most of us would agree that's really a questionable result. Did we actually really make him better? So I guess the thing that has come up time and time again about the role of a fusion, how early we should do it, and what are the things that can accelerate a fusion outcome. And certainly one of the things that we can agree on is the joint is very comminuted and cannot be reconstructed. And if you have other associated joint pathologies, then it's certainly worth considering a fusion. But my first message is that not all calcaneal fractures are the same, obviously, and therefore not all calcaneal malunions are the same. And I think one of the things that I kind of picked up as I went on and did more of these is that history and examination, I think, is absolutely critical. Trying to identify the pain generator and what the patient's problem is really sort of dictates the algorithm. I kind of always compare treatment of calcaneal malunions to a flat foot reconstruction. And I was always taught to write down the deformities in a flat foot on one column and have the surgical solutions to it on another column. And you would address the individual parameters of deformity with each surgical solution. And I think the way I kind of look at calcaneal malunions is the same. And that's why I find classifications, certainly whether it's the Zwift or the Romelt or even the Sanders one, not hugely useful in terms of dictating treatment. So I just want to highlight a point with a case illustration. It's a 47-year-old involved in a road traffic accident, multiple different injuries, open fractures as well. And he underwent a calcaneal fracture fixation and an IM nail of the tibia. I saw him about three and a half months down the line. That's his nail in his tibia. And you can see pictures of the calcaneal that was fixed originally. So when I got to see him, it was just under 4 months. You can see the bolus angle is lost and it's virtually flat, but with a huge massive bump underneath the fibula with a lateral wall blowout. And that's the CT, which confirms that subfibular impingement with that widened heel. And then 7 months down the line, he comes back to see me. He lives outside. He's not native to Singapore. He's got a tibia that hasn't healed, questionable at 7 months. So he then goes back to his native country, has the tibia nail revised. The tibia then progresses to heal, but he still complains of foot pain. The subtalar joint is painful, so he has the subtalar fusion done in the same setting as having his tibial nail revised. And that was what's done. The tibia then goes on to heal, but the picture on the right shows what was done for the subtalar fusion, but that continues to be painful. He still has a non-union with lateral wall impingement, and that is partly because the alignment wasn't quite restored. And so I got to him and ended up having to shift the heel further, medialize the lateral side of the calcaneus, but also to reduce the sublux TN joint with a revision subtalar fusion. These are some II pictures taken from the time of the operation. I don't have the final pictures, I'm afraid. So I think this case kind of illustrates the detrimental effects or the consequences of malalignment to begin with. So my second message is that alignment should really be corrected at the earliest available opportunity, and that is really possibly at the time of the acute fracture, if possible. And if not, then it continues to come back to haunt us. This is a 27-year-old construction worker with a closed injury 6 months ago, heel and forefoot both in varus. And we've kind of seen a similar case already, but this is slightly different. This patient, so I ended up doing a calcaneal osteotomy and subtalar fusion, not truly appreciating the consequential effects on the midfoot and the forefoot. 5 months down the line, his forefoot is still insupinated. He continues to walk on the lateral border of his foot. And so I come back and end up having to derotate the midfoot onto the hindfoot with, at the level of the navicular cuneiform joint. So the late fusion, we've talked about this already. I'm not going to dwell on this a lot, but in trying to correct the alignment, restoring the height, reducing perineal compression, I think these are amongst the goals of late fusion. In my practice, I would do more of a J rather than an L-shaped extensile incision. I find the flaps easier, they heal better. Sinus palsy and a calcaneal osteotomy, I would do 2 incisions to try and address both. I wouldn't hesitate to do a medial and lateral incision. We've talked a lot about bone block or no bone block. I won't dwell into that a lot, but I think patient selection is very important in trying to make that decision. When I'm doing a medial incision, I go down the bed of tip post-tendon and through the deltoid ligament. It gives me better control of the heel in its correction and the shift. And a lateral incision would be a lateral oblique incision centered over the lateral wall of the calcaneus, and also one the sinus tarsi to help me with the subtalar fusion. And this is an example of the type of shift that you can achieve with the calcaneal osteotomy and trying to restore a mechanical axis. And then fixation with screws, headless compression screws, and this is what I typically use. And that's just an example of a tuber that is in varus and been shifted through the mid-body of the calcaneus. And finally, this is just an example of an interposition bone graft that's used. And I think this is a learning point for me as well. Perhaps for me, the thing that I would change really moving forward be a bit more of tricortical iliac crest graft rather than allograft, which may be the reason why I have seen some non-unions when doing these kind of distraction procedures. So my third message is heel slide and arthrodesis are useful adjuncts to achieve alignment. Keep in view gastroc recessions and supramalleolar osteotomies. I do a fair number of gastroc recessions in conjunction with these procedures to try and get the alignment better, but always look at the mechanical axis, and I think that's very important. And that's it, Rajesh.
Thank you very much, Go. And we know that it is like almost 12:45 a.m. in Singapore. Right. So thank you very much for being with us. And before we move further to both the foreign faculties, can we have extension of another 15-20 minutes more, Dr. Go and Dr. Tom?
Yes.
I'm available.
Okay, so Dr. Tom, your comment on to the last case by Go. He uses both medial as well as lateral approach.
So I enjoyed the presentation. I think the takeaway messages were perfect. The combination of a medial lateral incision is difficult for me because going medial, I just find there are so many nerves and so many vascular structures that I tend to shy away from the medial approach. But looking at the way Dr. Gao presented that certainly is an option, and it's something that I may try the next time. It is important to get a full understanding of your anatomy in the abnormal sense to make sure you're able to correct it into the normal sense. And that's the takeaway message that I got from the presentation. So I thought it was terrific.
Yeah. Any question, Maninder or Kamal or Pradeep? Any question to Dr. Goa? Yes, Maninder.
I have a question to all the panelists and Dr. Rajiv Shah, you as well. Have you had experience with 3D printing of the calcaneal malunions and to design where the osteotomy exactly should be? Because what we need to is to restore the exact anatomy back, and that's what the aim should be. And I've had a few cases where Pradeep also showed a case in his presentation of a 3D printing, and I think it really adds on to the 3D visualization along with the CT scan, a 3D printed model of the calcaneum. I don't know whether, I just like the opinion of the house of what, if you've had any experience with that.
Yeah.
So may I?
So Maninder, so far as I am concerned,
yes.
I do not know, maybe because of vast experience of managing malunions, I had never had experience of using 3D printing. I have used 3D printing for so many of deformity correction, where I really need triple osteotomies. I've used 3D printing for total talus replacement or for avascular necrosis of the talus. But I've never had any occasion where I've used 3D printing for calcaneus malunion. But the opinion of other panelists.
So can I? Yeah. So in right 2020 only, there is a paper by Remelt. I think we all acknowledge that the work done by Remelt on malunion calcaneum is really phenomenal. He's the one who came up with this classification of grade 1, 0 to grade 5. So he writes right in the beginning in the assessment, he says, you don't need even 3D reconstruction to analyze your case. You just need a 2D reconstruction. So the printing is a step ahead, and he clearly says that 2D reconstruction is enough. And actually you start analyzing your pathoanatomy. You can do, I think, very well, you can analyze all your cases in 2D reconstruction. So I don't think so that it will be rather an overkill, spending enough money, spending enough time to do a 3D printing, and probably do not get any advantage over what information we have over 2D reconstruction images.
Yeah, Dr. Ajoy.
Yes, sir.
Dr.
So can
Ajoy, our
yes, sir.
secretary with his opinion, please.
So regarding 3D printing, so we need not actually print these things. What we can do is, there are so many softwares which are available. There's Mimics which is available. If we can just feed the DICOM images to that, we can get a 3D model, and we can cut it on that the way we want it on the software itself. We need not actually go in for printing. So if we want to rehearse the kind of osteotomy that we want to do, have the model on your computer, plan out the where we want to do the cuts, and we can go ahead and do the osteotomies accordingly. The wastage is not there.
Any other opinion? Pradeep, please.
So I agree with, so I've read a lot of papers of Zwip and Remalt as well. And it comes back again to the same point. Because Rajiv Shah sir has done 65 cases of malunion in his series, he's able to visualize everything in his mind with the 2D, with the X-rays. If we actually look at Remalt's paper, all his paper, he doesn't even give his CTs. He just gives standing AP, lateral and axial views, and he tells about the pathoanatomy. So especially for people who are starting, I think getting a CT scan, 2D, 3D reconstruction, and for the first few cases, for such complicated cases, having a 3D model right in front of you to understand what is happening really makes sense. And the example which I showed, that patient not only had a subtalar, had an ankle involvement, and right going up to the midfoot, the Chopin's joint as well. And it was very helpful when I planned the osteotomy, because that was a very different osteotomy which I've done, which had to go right up to medial. So I had to be very careful how much I go on the medial side. So I think there is a role of that. Initially, you get first few cases, get a 3D printing model, and it's not very expensive as well. And probably I think most of parts of the India is serviced by these companies. Have a look at the 3D model, practice it, plan it properly. That really reduces your intraoperative time, your intraoperative surgical time, complication rates, and your radiation as well. Yes, you can get software, and we are working on that as well. But I tell you, the technical guys and the software guys are still not up to it. What you can do it.
Okay, so since somebody has talked about the classification, it has been something very nearer to my heart. Yes, these classifications are fantastic, but Stephen and Sanders gave classification on the basis of just 23 cases. Thereafter, there are no case series onto which Zwip and Remalt has given classifications. But looking at this, both the classification, say if we talk about a deformity-based classification by Zwip and Remalt, they have not talked about involvement of calcaneocuboid joint, which is there in 25% of the calcaneus fracture. You have involvement of calcaneocuboid joint. The late cases of calcaneus malunion, they present with arthritis of other joints, midfoot joints. Even I had a case of arthritis of ankle joint following the calcaneus malunion. So these classifications talk of only subtalar joint, but you do have problems of other joint. The deformities which are talked do not cover soft tissue deformities like equinus deformity, like clot toe, hamarto deformities. the differentiation into a tongue type versus interarticular type is not possible with this classification. And very, very importantly, these classifications do not talk about the nerve issues, issues of the tendon, issues of the soft tissues, and post-surgical malunions are out of this classification. So these are certain important points. And the most important observation, which three series, R series as well as two other series had, is there is an overlap of cases into SWIP and RAMID. You would be able to classify a case of type 0 into type 3 also in SWIP and RAMID. So there is a confusion, and we had such cases and the similar observations were there in the literature. So this is just a point I wanted to make with respect to the classifications. Any other comment from any panelists? Otherwise, I go to a few of my slides. Anybody wants to say anything? Okay, with the permission of Dr. Go and Dr. Tom, I am going to share my screen. Okay, are you all able to see my screen and listen to me?
Yes,
Indrajit?
Yes. Yeah, we can.
Yes, sir.
Yeah.
Yes, sir.
Okay, so one very, very important tip which I want to give is whenever you are dealing with the post-traumatic arthritic cases, post-traumatic calcaneus malunion, try and fuse all three joints because you want a solid fusion. So I always like to fuse all three joints for a post-traumatic such kind of calcaneus malunion. Second important thing, I like to add additional anterior screw described by Roger Mann. So in almost all of my cases, I like to add additional anterior screw. And the third tip is that not all the time you have to look at the iliac crest to get the bone graft. You have a calcaneus from where you can take the bone graft. Look at this, I've taken bone graft from the calcaneus posterior superior angle. You have to be a little careful on to not damaging the tendoachilles. And then this kind of graft can come and fit like this. So this is one more bone graft site for you when you are dealing with calcaneus malunion. Any question or comment before I move to my one or two cases? Okay, so I move further with one or two cases. Okay, so this was a 31-year-old obese female who had a calcaneus fracture in United States of America, and this is how she underwent a fixation of a plate. And you could imagine what issues she would be having. So these x-rays were sent to me and I said, ask your surgeon to immediately remove the plate because the plate is also obstructing and plate is giving a problem of sural nerve neuralgia. So she underwent removal of the plate. She continued with burning pain in the sole, burning pain in the lateral border of the foot, and probably these two medial screws also gave something like tarsal tunnel pain. So surgeon again went in and removed the medial screws, but still the pain persisted. And then she went on sending me the x-rays. She went on asking my opinion on phone call. And then I said, no, you need to come down. So she came down. This is the standing x-ray showing subtalar joint arthritis, talar dorsiflexion, contracture of the tendoachilles. Heel was into varus. There was shortening of the heel. There was sural nerve injury. There was posterior tibial nerve injury. She also had heel fat pad syndrome and claw toes. So this is where the problems, and this is what I classify as my type A, D, I, and O, where you have arthritis, deformity, implant, nerve issues, and soft tissue problems. So on exploration, there was non-union between body and the anterior fragment. And subtalar arthritis was also there. So what I did, I took 2 iliac crest bone graft and then a bone graft between anterior process, anterior part of the body and anterolateral portion, and the bone graft between talus and calcaneus were put in and they were fixed. So body and anterior fragment graft, a graft between talus and body. Patient also underwent a medial exploration, neurolysis and tarsal tunnel release was done. And she also underwent claw toe correction like this and went on to heal. The second case was a case which was about 12 years post calcaneus fracture. He presented to me with a subtalar joint arthritis, shortening of the heel. As you can see, there is talar dorsiflexion also. There is a plantar exostosis, which required a separate plantar approach. Tendoachilles shortening. Heel was into valgus, then varus. He had a claw as well as hammer toe. And he had a medial exostosis, giving rise to secondary tarsal tunnel syndrome. And then this case required multiple surgeries, distraction subtalar joint fusion, talar dorsiflexion correction, plantar exosectomy, correction of the heel valgus, medial exosectomy, tarsal tunnel release, and correction of the claw toe. And the third case had a subtalar arthritis, arthritis of the calcaneocuboid joint, heel varus, lateral wall exostosis together with the claw toe. And then with this kind of an extensile lateral approach, which was taken dorsally and distally, I did a dowel type calcaneocuboid fusion with packing of the bone grafts taken from the proximal tibia and did a calcaneocuboid plus talocalcaneal fusion. So distraction subtalar fusion, in situ CC fusion, lateral and posterior wall exosectomy, correction of the heel varus, hammer toe and mallet toe correction, like this. So this is how the ultimate end result was there. So before I go for 5 cases where I just want rapid fire round in view of having opinion of panel, is there any comment? Is there any question? I would, be keen to answer that.
So then there was a question, sir, that how you go into the anterior and the middle facets when you're doing the subtalar arthrodesis.
Yeah, so whenever you're going to do subtalar arthrodesis, you can definitely reach to the anterior and middle facet easily. You just have to go beyond your sinus tarsi region, and then there you find your anterior and middle facet. You might even in a beginning, if you're not experienced, you might like to extend your incision and go up to the middle and anterior facet.
So I have a question.
Yeah, please.
Yeah, sir, with all this complex correction in the hind foot, you do the forefoot correction also in the same sitting, or you give it a try of physiotherapy and see whether things get corrected on their own or do a later stage?
No, I think forefoot correction, all these corrections in all these cases I've done in single sitting. But I think it could be a good idea where you could think of doing it in a stage manner. I don't have any objection to that.
Another question by Dr. Kamal Dureja, sir, he himself.
Yeah.
What do you do to the sural nerve if there is sural nerve neuritis?
Yeah. So most often than not, if there is an offending implant, you just remove the implant. That works well. Or else in 1 or 2 cases, I've gone proximally and I've done resection of the nerve and burial of this nerve into adjoining tissues. I would like to have comments of Dr. Tom followed by Dr. Gao onto these 3 cases.
Rajiv, what a nice job. I mean, those are very difficult cases, and I'm glad you identified the anatomy, and I agree with the way you address them. I am also impressed, especially in the first case, how well you dealt with the soft tissue, because when you look at the lateral border of her foot with all those incisions, I mean, it takes courage to make another incision laterally in that area.
Go.
Rajiv, that's phenomenal. I mean, I think the combination of deformities is huge. And I think that question that came earlier about it doing in a stage fashion, just give us some thought, where, you know, especially for those starting out with this sort of a problem, I think is a good approach. My question is, have you had experience whereby doing a deformity, especially in cases like this where there's severe soft tissue contracture on one side, or even nerve-related issues on one side, by doing a deformity correction, you then end up with a traction phenomenon on the opposite side?
No, not really. In fact, all these cases I had to go medially also. If you see, these 3 cases, 2 cases I had gone medially, and I had done the medial release. The case like Dr. Vache showed, the kind of an osteotomy, I mean, kind of the correction he aimed with the lateral sided osteotomy. I would also like to go like your approach, Ko, where I am going to put in a medial as well as lateral approach for the correction of such a kind of bad deformity. If you remember, the tuberosity was displaced quite medially in Dr. Gurunath's case, which I would have gone with a medial as well as lateral approach. So many times I am obliged to go medially as well as laterally. So I has had no issue of traction onto the tissues. So if there are no further questions, I would go ahead with a rapid fire round. These are the cases which are sent to me for opinion, and I don't have much details of these cases. Like if you want that I want a CT of this case, I may or may not have. So it's a case which I want panelists to opine. Case number 1. So male 27 had a road traffic accident like this, and something similar to the last case you saw, Go.
Yeah.
And then at 12 months, this patient comes with pain, inability to stand, inability to walk. Kamal, what do you read in this X-ray?
Yeah. So this is basically a complex fracture dislocation.
Axial view,
Yeah, so this is a complex fracture dislocation where you have talonavicular dislocation in addition to the fracture and dislocation of the calcaneus. So these are the cases where you probably, these kind of cases will have a lot of soft tissue problems. So you have to handle these cases by understanding them in the CT. I mean, if you ask me to do these cases just on the basis of X-rays, probably I would not touch them. I would definitely like a CT analysis of these kind of cases.
Okay. So you have a CT, and then how are you going to approach this case? Do you think there is a fracture dislocation of calcaneus? Is there a dislocation of calcaneus in this case?
Yes, I mean, the fracture is quite medial here, probably in the sustentaculum tali, and the whole of the calcaneus has moved laterally, you know.
Okay. Maninder, you suspect something else in this case, Maninder?
Well, you've had, this is a complete talar sort of dislocation, except for the ankle. We don't have the ankle X-rays, but I suspect this is, along with the calcaneal fracture, the whole of there is a midfoot. You see the calcaneocuboid joint is still out and arthritic. There is loss of the talar head with the talonavicular arthritis, and the talus is, talonavicular articulation is completely disjointed and out of line. So this is a severe injury. Sort of, it's a midfoot, hindfoot, and ankle. So there's ankle arthritis now as well in the lateral view. So, this is something which we need to clinically assess. What are the clinical ankle movements? What are the midfoot movements? What is the position of the foot? Is it plantigrade? And what is the position of the, the forefoot as compared to the hindfoot? And then we have to plan for, a correction to get a plantigrade foot. Because at the moment, it looks like, the calcaneum is not really weight bearing on the heel, on the back of the heel. It's more weight bearing on the middle part of the calcaneum. So it's sort of, the whole of the bowler's angle is completely lopsided. So I think we need to plan that out with sort of, clinical pictures. The clinical examination, I think, would be the key here, along with the CT scan.
Dr. Tom, are you suspecting something else in this case?
Well, I'm suspecting a lot. Obviously, this is a high energy injury. You have issues with the ankle joint, subtalar joint, the transverse tarsal joint. We don't even know what the foot position is. We are concerned about soft tissue, compartment syndrome. So I am suspecting a lot, and I agree with what the panel has said, trying to get more information on the bony alignment as well as, continuing with the physical exam. So it's hard to make a judgment with just these x-rays.
Yeah.
Is there any infection?
Yes, exactly. So that is what I was wanting anybody from panel to come up and say. There is a draining, there was a draining sinus, and you can see there are areas.
Osteolysis and bone formation.
Yeah. So like over a period of 1 year, this much destruction of the joints in a calcaneus malunion may be a very bad injury initially, cannot happen. So there was a infection in this case, which was also associated with such a case. So there's an infection, arthritis of the ankle, subtalar, calcaneocuboid, talonavicular joint with dislocation of the talonavicular joint in this case. So just to bring to the notice of the esteemed panel that these are the kind of cases which do come in our setting. So this is one more such case, Dr. Gaur, who presented at 9 months. There is no infection, but this is the X-ray picture, lateral view. This is the medial and lateral clinical picture, and this is how he stands. And he has come to you to get something better. What would you like to offer, Dr. Gaur?
Ankle foot orthosis.
Okay, great. Okay, okay. Anybody, Pradeep, would you like to? I think you've seen this case. Okay,
we've seen this last week. Yeah.
Yeah, Dr. Vora.
So I won't like to do much. I'm with the AFO. And if we really have to do, we have to take help of the plastic surgeons in these cases.
So you have a fantastic plastic surgeon in your institute.
Yes, we can. Now, basically, there is a loss of declination. So you have to do a distraction in this case. That is very important. Then, of course, as Dr. Kamal Dureja said, that you need to have a CT in such cases. It is very, very difficult to appreciate only on the lateral view what you need. On the lateral view, I can only appreciate that there is a loss of the height and there is an increased the talar declination has to be restored and there is an anterior impingement. But I cannot see the status of the joints. The only thing is you can just open from the posterior side, do an osteotomy, and I need to have a consult of the plastic surgeon first, whether he'll be able to provide me coverage or not. So the prime problem here is a soft tissue, then more of a bony problem.
And what are you going to do with okay? What are you going to do with tendo Achilles? Dr. Vora, what are you going to do with the tendo Achilles?
Tendo Achilles. I don't know what has happened here, but there doesn't appear to be any tendo Achilles here. So just realign the foot, and then you may even do a TTC fusion in these cases.
I think there's a small fragment of bone which is avulsed up, no, sir? That's the tender attachment bone.
It's an avulsion of the Achilles tendon because Achilles small tendon, fragment from the tuberosity has gone up. Yeah.
Yeah, but you could easily actually do a FHL because that fragment is not going to come down. It's been there for quite some time. So instead of that, probably just leave it. If it doesn't come down, just leave it and take the FHL and put it onto the remaining calcaneum tuberosity.
The issue is the soft tissue, yes.
Kamal, I'll just stop you for a minute because Dr. Tom Lee.
Yeah, he has to leave, sir.
Yeah.
He has to leave. So,
sir, thank you very much for being with us.
Thank you very much.
Thank you very much for blessing us. Keep blessing us.
Thank you, sir.
Thank you, sir.
And have a great day.
Thank you, sir. Thank you, sir.
Thank you, Tom.
Okay, Kamal, go ahead with your comments, please.
So if we are looking at the problems, we have an Achilles tuberosity avulsion. We have a problem of incongruity of the congruity of the talocalcaneal joint lost. We have the problem of the length of the calcaneum which is lost. We have the problem of height of the calcaneum which is lost. Now, if we are wanting to address all the issues to make his gait better, first issue would be to make the skin at the back better, because unless we make the skin better, the scar is going to fall apart and spoil all your reconstruction work.
Right. Okay. So, doctor, anybody has any comment, or I move to, or we
Please
might
go ahead, sir. We are already quite late, sir.
Okay. So, Indrajit, we'll wrap up here.
I'm getting
Thank you very much, Dr. Goa. It's now 1:15, I guess.
So what we did, sir, please show.
Yeah. Okay. No, I have given A4 to this patient, and fortunately, he has not come back to me.
That's good. That's good. That's the best thing.
So, thank you very much, panelists. Thank you.